So welcome everyone. This is Professor Timothy Carey. I'm the inaugural director of the Institute of Global Health Equity Research and the Andrew Weiss Chair of Research in Global Health at the University of Global Health Equity in Rwanda. It's a huge pleasure and privilege for me tonight to be able to welcome you to the Implementation Science webinar, where we'll be discussing why implementation is needed now more than ever before. We'll be covering some general aspects of what implementation science is, as well as lessons from specific applications. And implementation science is particularly important at the University of Global Health Equity, where we're reimagining the way in which health professionals can be trained in order to eliminate global health inequities, particularly for poor and vulnerable populations. And a key aspect of that will be research and research training. So we're also reimagining the way that research can and should be conducted in resource poor settings. And not only can the way in which research can be conducted, but what happens to that research and the way in which research findings should be making health service and health service delivery and health care better for the people who need it most. And that's the real message from tonight. So I'm wanted to welcome you to the webinar tonight, but I also want to welcome and introduce our four panelists, the speakers who will be with us tonight and sharing their knowledge and expertise with us. So it's a real treat for me to be able to introduce you to Professor Kenneth Scher, who's a professor in the Department of Global Health at the University of Washington. Dr. Scher's research focuses on developing and testing practical solutions to support data-driven decision-making and service integration into the primary healthcare framework to improve health system coverage and quality. He's led the development of implementation science training curricula at the University of Washington Department of Global Health, including the development of the PhD program in implementation science in 2012. I'd also like to introduce Dr. Quinhês Fernandes, who has worked across all levels of the health sector in Mozambique since completing his training in medicine in 2002. During his career, he has served as Provincial Health Director and also Deputy National Director of Public Health at the Mozambique Ministry of Health. Dr. Fernandes has a particular interest in measuring health systems' strengthening impact. Currently, he's pursuing his PhD in implementation science at the University of Washington and is co-principal investigator of the Integrated District Evidence to Action program to improve maternal, newborn and child health, which is being implemented in 2 Mozambique provinces. Our third speaker tonight will be Dr. Lisa Hirschhorn, who's Professor of Medical, Social Sciences and Psychiatry and Behavioural Sciences at Northwestern University. Starting as a public health researcher and HIV clinician in the 1980s, Professor Hirschhorn ran the HIV medical care program at Dimmock Community Health Centre's HIV program and was director for implementation and improvement science at Ariadne Labs, a partnership between Harvard School of Public Health and Brigham and Women's Hospital. At Northwestern University, Feinberg School of Medicine, Professor Hirschhorn serves as professor in the departments of Medical, Social Sciences and Psychiatry and is a member of the Third Coast Centre for AIDS Research, as well as focusing on the application of implementation science methods to effectively measure and improve implementation and quality and effectiveness of care in the US and a number of countries in Africa. Our final speaker tonight will be Professor Agnes Binagwaho, who's a Rwandan paediatrician and current Vice Chancellor of the University of Global Health Equity, or UGHE, which is an initiative of Partners in Health focusing on changing how healthcare is delivered around the world by training global health professionals who strive to deliver more equitable, quality health services for all. Professor Binagwaho has served the Rwandan health sector in high-level government positions, first as the Executive Secretary of Rwanda's National AIDS Control Commission, then as Permanent Secretary of the Ministry of Health, and 5 years as Minister of Health from 2011 to 2016. Professor Binagwaho currently serves as a Senior Advisor to the Director General of the World Health Organization and also as a Senior Lecturer in the Department of Global Health and Social Medicine at Harvard Medical School. She's a Professor of Pediatrics at UGHE, as well as an Adjunct Clinical Professor of Pediatrics at Dartmouth's Giesel School of Medicine. Professor Binagwaho's academic engagements include research in implementation science, research on human rights to health, health services delivery, systems strengthening, HIV/AIDS, and pediatric care. She has published over 190 peer-reviewed articles. So that's the lineup of our speakers. We're in for a huge treat of information and learning tonight, which you'll be able to contribute to, and I really hope you do. We need to establish the standard kind of housekeeping before we start. For the duration of the webinar, as attendees, you'll be on mute and with your videos off. But the session is being recorded, so questions that you contribute that we ask of the speakers will be part of that recording, and you can help to make this webinar the amazing event that it's going to be by contributing some questions which I'll be asking of the presenters in the final 30 minutes of the webinar. We would encourage you all to share questions via the question and answer box, but you can also share them through the social media channels that are being displayed right now. And we would also encourage you all to share your thoughts. Only some questions will be able to be asked given the time we've got, but it would be great if you would share your thoughts via these channels as well. Okay, so that's more than enough from me for now, I'm sure, and I'll look forward to handing over to our first speaker, Professor Kenneth Scher. Thank you.
All right. Well, good evening, everybody, or morning, depending on where you are. If we could go to the next slide. Much rather look at not myself at this early in the morning Seattle time. And first, I want to thank you all for organizing this panel. It's great to be together with such an esteemed group of panelists and talk about a field which has been emerging over the past 15 years, and I think is really a very important field for driving large-scale change in global health. And by large-scale change, I'm referring to improving how we understand and deliver evidence-based interventions to the health of populations. So really thinking about treating populations as our goal and leading to improved population health. I want to recognize before I start how implementation science is a field that is evolving. The Journal of Implementation Science was only created in 2006. The large national conference on implementation science only started in 2009. So we're in a field that has been evolving greatly over the past 10 to 15 years in terms of the definition of what implementation science is, in terms of the key methodologies for implementation science, and in terms of furthering our understanding of how best to deliver evidence-based interventions to the benefit of populations. I want to recognize that implementation science as a field came largely out of high-income country settings, in particular the US healthcare system, which has delivery approaches that are quite different from at least where I have worked in global health. And because of that, I think we need to be always conscious of the need to reframe implementation science so that we are best meeting the needs of different healthcare systems and populations in diverse settings. So what I would like to do for the next 8 minutes or so is to provide an overview of implementation, the motivation for implementation science, what it is that we are trying to address through this field, and as well as a definition that we have been using at the University of Washington for implementation science that is a bit different from a definition you may find coming out of the United States National Institutes of Health or high-income country settings, largely because of really the different contexts and where we're working. Next slide, please. So many of you may be accustomed to thinking about cascades of services where you have leaky cascades or individuals or groups that are systematically lost along the way from entry into a service all the way through completion of that service. Similarly, we can think about the publication pathway and how original research is conceptualized, is developed, funded, tested, and then gets into publication. The results of research get into systematic reviews and guidelines, and then hopefully into the benefit of populations. Next, please. And it's estimated that because of this leaky cascade, that only 14% of original research actually gets to benefit patients over a 17-year horizon. So this is really one of the beginning motivating factors of implementation science, is to expedite the translation of research into the benefit of patients and populations, but then also trying to maximize how much of that research meets the needs of populations and patients. Next slide, please. And this brings us to what has been termed as the no-do gap, or the gap between what we know works, largely from efficacy trials, so evidence-based interventions, or interventions that have a very solid evidence base and we know works in controlled settings, and doing it correctly at a large enough scale to actually lead to improvements in health outcomes. And this gap continues to grow as our advancements in medical science continue to outpace their application. And as a result, we have an addressable disease burden that continues to endure. So consider that there are over 10 million annual deaths from diseases that have proven, and importantly, low-cost prevention or treatment strategies like tuberculosis, HIV, preventable child deaths, and maternal deaths. And on the right, you can see an estimate from the Rufiji Demographic Surveillance System, where they estimate that over 85% of the burden of disease in the Rufiji district in Tanzania could be addressed by available cost-effective interventions that are simply not getting into the delivery system effectively to treat patients and to address this avoidable disease burden. Next slide, please. Now, thinking a bit more systematically about the translation of evidence-based interventions to the benefit of health outcomes, you can think about different steps of translation and how different research endeavors fall into the different steps of translation, what has been called the translational highway. And so you can speak with researchers all across this continuum and find that they're asking and answering different questions. At the upstream level of discovery, which has been coined as the T0 or T1, really that first step of translation, researchers are working to define mechanisms and targets, identify new diagnoses and treatments, and develop prevention methods. So this is also termed as bench to bedside. People working in labs, working in animal studies, and to develop candidate vaccines, diagnostics, and therapeutic mechanisms to then bring that into the human population or the bedside. Which brings us to then this second step of translation, or the developmental stage, which are largely efficacy trials where you have a candidate biomedical intervention, or it could be a behavioral or social intervention, and you're going to test that intervention in a controlled environment to demonstrate whether or not it works in a highly controlled setting. And then emerging from these efficacy trials, we get to the complicated black box of delivery, or that third step of translation. And this is where largely we're going to situate implementation science, where we're exploring how to deliver evidence-based interventions in real-world settings across multiple contexts in order to then improve health outcomes. So two things to underscore here. One is that this box of delivery, or that translation of delivery, is essential to bridge the gap from a known evidence-based intervention to actually improving health outcomes. It is really that fundamental step of translation. And the next is that it is a black box, meaning that it is these are very complex systems. We don't exactly know how to make them work to better deliver evidence-based interventions, and often can take a lot of resources. So also have heard of delivery systems as black holes because of the resources needed to deliver evidence-based interventions for populations. And then that last step of translation is to ensure that the improved health outcomes are being achieved. And the research questions in the fourth step of translation focus on studying influences on the health of populations. And I'm going to argue that implementation science is actually going to include measurement of improved health outcomes related to all the upstream steps to get from discovery all the way to improved health outcomes. Next slide, please. And so this brings us to how we are defining implementation science at the University of Washington. And as I said before, there is no standard definition of implementation science. I think what everybody can agree upon is that implementation science is focusing on questions about how to close the no-do gap, how to ensure that we are delivering evidence-based interventions that are maximizing their potential to the benefit of populations, and that it is a multidisciplinary endeavor, that we really need to be thinking about what different disciplines can contribute to answering these tough questions about how to deliver evidence-based interventions. So we're looking at implementation science as a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, sustainability, and relevant coverage. So there's a lot here. Let me unpack it a bit. So it is a systematic scientific approach. We are looking at this as a research endeavor where we are learning about how best to deliver interventions and lead to improved health outcomes across multiple contexts in a way that is generalizable, so that we can take those learnings and learn and bring them to other delivery systems in other contexts in a way which can be shareable. We want to focus on getting what works out there. And what I mean by what works are those proven evidence-based interventions that come out of efficacy trials largely. And we want to do it faster, so it doesn't take 17 years to get a fraction of our knowledge on what works to the benefit of populations. We want to do it with fidelity to ensure that we have the active ingredients of those evidence-based interventions and implementation strategies in place so that we can, so that it does benefit patients and populations. We want to do it efficiently and maximize the resources that we have with high quality, I think speaks for itself, sustainably, and relevant coverage. And the relevant coverage, realizing that we're not always treating populations in a monolithic fashion, that we are often focusing on coverage for specific populations and can be very targeted in trying to address unmet need in specific population. And we're looking at this as a framework of methods that contribute to improving delivery systems and leading to the delivery of evidence-based interventions. And so I'm not going to go through all of these, but just to underscore that this is a multidisciplinary endeavor, and that we are going to be borrowing tools and approaches that come from disciplines across the gamut. It can be from the business world, from psychology and organizational psychology, from industrial and systems engineering, from the social sciences, as well as from more of the traditional health sciences. So it's not something that we are going to achieve on our own in a silo as public health or global health professionals, but instead is going to require thinking holistically about some of those sticky questions or difficult questions around delivery of evidence-based interventions, and it's going to require a unified effort to overcome those questions. So I want to stop there, realizing we're short on time, and thank everybody for their participation.
Well, thank you, Professor Sher. That was absolutely fascinating and jam-packed, and I think incredible when you put it in the context of the 17 years that it takes to get research into health benefits, and just in terms of the tangible consequences of not doing that faster in terms of lives actually being lost. I think you've really set the webinar up for a great following in terms of how important this area is. And we'll be now hearing from Dr. Kinesh Fernandez. Thanks so much, Dr. Fernandez.
Thank you, Professor Timothy, and good morning or good afternoon for everyone that is in the webinar, depending on where you are at this point. I'll be talking about implementation research capacity building, particularly some aspects that I believe may be critical when we want to take implementation research capacity to scale. Can we go to my third slide, please? Next. Next slide, please. This is the outline. Okay, thank you. Building off what Professor Hirschhorn was saying, today more and more there is the recognition among the academic and global health community that implementation research has an important role in improving coverage of evidence-based intervention, as was saying Professor Carey. There is some consensus that implementation science helps to create an environment such that policymakers, program managers, and researchers can work collectively without barriers to achieve a stage in which decisions are made based on the best evidence that we have. That is a stage where research is really demand-driven, follows analytical approach, is timely conducted, and that policymakers effectively use the evidence to improve healthcare delivery. Despite the implementation research benefits that we all know, few has been done to building implementation research capacity, particularly in low middle income countries. There are still a few cases where researchers and policymakers actually work together. A recent systematic review showed that less than 25% of implementation research studies, and when I say implementation research studies, I mean studies that follow principles of implementation research, actually were conducted both by researchers and policymakers. This highlights that in practice, bringing together policymakers and researchers has not been an easy task, and we know why. There are still several trade-offs, and for example, we know that researchers do care about implementation research or any kind of research being methodologically rigorous. They do care about ensuring fidelity of the intervention design. For most of the researchers working in the field of implementation research, it's critical that implementers have less influence in the research itself, since that could bias or reduce the transparency. On the other hand, for policymakers, do matters that research is aligned with the institutional needs. That is, the research has to be demand-driven. Timeliness, usefulness, and allowing adaptations to solve problems is really determinant for policymakers. So to advance implementation research, it's really critical to ensure a good balance between researchers and policymakers' expectation. That's why my understanding is that it's very important to establishing a learning system and solid capacity building embedded within the health system to ensure that we minimize these barriers or these trade-offs that I have highlighted. Can we go to my slide, next slide, please? So who should we target and why when we are implementing an implementation research capacity building program? As Professor Carey was saying, the field of implementation research has been evolving fast. So it's really natural that we still have philosophical and conceptual debates and lack of consensus in most of the aspects. However, I feel like there is some consensus that implementation research should be applied in the real world, that is embedded within the health service delivery system. For me, this makes a strong argument to design capacity building programs that target all those that play a critical role in designing, planning, implementing, scaling up, and evaluating public health intervention. Because of this fact, it's hard to me to think about embedded implementation research or implementation research without engaging both researchers and implementers, or researchers and policymakers. So any capacity building program should prioritize policymakers, program managers, researchers, and local partners across all levels of the health system. Of course, we need to innovate, and we need to make sure that we address each group's specific needs. For example, we don't need to spend time and resources to train a high-level policymaker to understand those complex statistical models that we really like to use in the field of implementation research. But I believe that they do need to know or to have the basic skills of implementation research to judge, to criticize, and to use results. I'm not saying, of course, that if possible, policymakers can be trained, yes, but probably that's not the priority. On the other hand, researchers also need to be able to understand the implementation context to evaluate it accordingly. Let me give you an example. In my career, I have led several initiatives to scale up evidence-based interventions. The last one I was engaged with was to scale up family planning through community health workers. And to be honest with you, I don't remember to have called a researcher to sit and discuss with me the best way to scale up that intervention. And today I realized that probably I missed a critical opportunity. Can we move to my next slide, please? Then how can we successfully implement an implementation research capacity building program, particularly in the context of low middle income countries, and take that to scale? There's no single recipe. I believe that context always matters. What works, for example, in Rwanda may not work in Mozambique or vice versa. However, there are features that should apply to most places. A capacity building program, to me, should have a clear evidence-based theory of change with clear pathways showing how the program should work and lead to outcomes. This is critical to ensure a good understanding of what works and what does not work, and therefore be able to adjust whenever needed. A capacity building program should be embedded within the health system structure and led by trusted and skilled people. And of course, like any other program, there has to be funds committed for it. And when I say trusted and skilled people, I'm not saying directly that it has to be a policymaker or a researcher, but at the end of the day, it has to be someone that has leadership skills, is trusted, and has the technical skills to carry on that program. A capacity building program should be people-centered, sustainable, and oriented to achieve concrete and measurable short and long-term objectives. This is something that, in my experience, we normally don't take that into account, and then that makes it difficult when it comes to try to understand the implementation process, and when it comes to understand or to try to improve the program. Can we go to my last slide, please? Finally, I wanted to end my reflection talking about opportunities for capacity building in the context of COVID-19. COVID-19 has created an excellent opportunity for collaboration. Honestly, I have never seen a situation where policymakers demanded for evidence like they are demanding today. There are many unknowns, and almost every policymaker is asking questions and seeking for answers. Researchers are being challenged with the most difficult questions today, and sometimes are not able to deliver answers timely. So to me, it's becoming clear that we need, or we have invested, we have not invested much in building capacity. And this is the chance for us to make that change. I'll stop here with a big thank, and I'm happy to get questions by the end of the presentations. Thank you.
Wow, thank you, Dr. Fernandez. That was wonderful. The idea that researchers and policymakers should be having more to do with each other just seems like such an obvious thing, but something that hasn't been done well at all yet. And I completely agree. I think as awful as COVID-19 has been, it has presented the world with some unprecedented opportunities, and it's great to see you picking up on that and really imploring us to do it better. Now we're over to Professor Hirschhorn to give us some more lessons about where implementation science can go and the benefits it can have. Thanks, Professor Hirschhorn.
Much, Tim. Next slide, please. So I'm going to actually go a little bit more, now that we've had this really wonderful approach of what implementation science is and what we're not so sure about, and how we can really sort of focus on building the capacity to do it, to actually talk about an example of how implementation science was used to really address both this issue about policy and implementation. This was based on a much broader initiative that's been through Gates Ventures to look at what are called exemplar countries, countries that are doing better in different areas than one would have expected based on their economic or their regional peers. And so again, reflecting back on what Kenny said, is that we actually know how to prevent a lot of deaths in children under 5. And selected exemplar countries have made significant progress in reducing them. So we do have some areas where people have been successful. But what's really missing is how and why. And so with a group of people at University of Global Health Equity, as well as in-country partners, we actually set out to design an implementation research to ask, why have these exemplar countries and how have they outperformed other countries with similar GDP change on under 5 mortality reduction? And we focused on 6 countries to allow us some both geographic diversity as well as country size diversity. But each one of them, as you can see, really dropped the mortality significantly between 2000 and 2015. These are maps that were developed for us by Simon Hayes' group at IHME. And what you can see here is that not only did they drop under 5 mortality, but in most of them, although not all, there was a fair amount of equity in terms of where that was dropped with some areas. And each one of them did this somewhat differently. Peru, for example, was a tremendous focus on equity, integral to the reduction of under 5 mortality, particularly as they transitioned to an upper middle income country. Ethiopia, as the second most populous nation in Africa, and some significant geographic and cultural challenges. Rwanda, following the genocide in 1990s, achieving one of the highest % reductions. Senegal, with a very comprehensive vaccination and integrated childhood, community-based childhood management of disease programs. And finally, Nepal, which achieved both under 5 mortality as well as quite remarkable neonatal mortality reductions, including during a period of conflict. Next slide, please. So how did we actually do this? So there's a lot of quantitative data out there that allows us to describe what happened, as well as to potentially model some of the underlying causes. But our idea was that we really, to understand this, and particularly to create the generalizable and transferable knowledge to help other countries, that we actually needed to do this through implementation research, to identify the implementation strategies, the contextual factors, the implementation outcomes, and for 7 countries, actually 6 of them have now been completed over the 15 years. But we also recognize, again, reflecting what Kenny said, that a lot of the frameworks that existed were really developed in high income and particularly US countries. And so we had to figure out how to develop one, as well as data collection tools to apply with implementation research methods. And then again, as Kinesh has pointed out, to make sure that we're partnering with key stakeholders by partnering directly with in-country organizations and helping to also transfer some of the implementation research skills. We also recognize that quantitative was not enough, and so this is mixed methods, looking at literature, evidence, qualitative interviews, quantitative analysis, as well as program and policy reviews. And then sort of synthesizing this to understand the relationship between the implementation outcomes, coverage, mortality in the country context, and critically to extract actionable knowledge needed by decision makers to adapt the lessons to their context. And this was all then done going back to the countries with stakeholder feedback to see, did we get it right? What didn't we get it right? And where was there still missing information? Next step. Next slide. So what we did was we actually spent a while looking at the existing implementation research frameworks, and we actually decided to combine them. And so again, this goes to this idea that implementation science is an evolving practice, and that you need to sort of figure out how do you make something that is really fit for purpose for what you're actually doing, while maintaining the rigor that actually defines it as research. And so what we did was we realized that Aaron's has a very good framework called EBIs, Exploration, Preparation, Implementation, and Sustainment. And we based it on that because we realized that that was absolutely core, that it wasn't just simply implementing, but it was the process of how they explored and how they prepared to be able to implement. We then had to adapt that because we realized that a key part of implementation was the adaptation. And so we actually developed something called EBIs. And then we also were very concerned about the contextual factors, and we derived from the consolidated framework for implementation research, which was a very strong framework developed by Laura Damroscher, but recognizing again that there were very different levels. And so as opposed to sort of the traditional that people may be aware of, we realized that we had to do the individual community and the national, but also the global, as well as Ministry of Health. And then looking at, again, the analyzing what were the implementation strategies that were being used and what were the outcomes, for example, of equity, of which would be sort of penetration or reach, but also acceptability, adoption, and fidelity. Next slide. So what did we find? We actually found that across these 6 countries, there was actually a common pathway for the implementation of the evidence-based interventions, as well as the other needed work. And on the left, you can see a theory of change that we actually developed, recognizing, again, a lot of us were our health system or healthcare focused individuals, that while access and quality care is critical and to reduce the fatality rate when somebody got sick, as well as evidence-based prevention, such as vaccines and insecticide-treated nets, that there were other work that needed to happen for prevention, such as, for example, WASH, or as we see with COVID, other types of prevention that are not necessarily healthcare related, as well as things which improve the resiliency of the family and the child, such as, for example, reducing stunting. And that the goal was then for us to focus really on the healthcare, health system delivered evidence-based interventions, but recognizing that this really had to be a partnership that existed to actually drop under 5 mortality. So the 5-step implementation process that we saw was, again, this exploration. These are some of the key examples of understanding and researching the problem, identifying multi-sectoral stakeholders. In preparation was choosing the strategies that fit the national context and priorities, and developing evidence-based guidelines and a plan for monitoring and evaluation. Implementation was, again, broad, training personnel and stakeholders, and associated with accountability frameworks and monitoring to be able to drive the next step, which was adaptation based on what was or wasn't working, but also on new evidence, such as, for example, new treatment of malaria. And then working from the beginning for sustainability in terms of funding, culture of evaluation, and integrating training and the capacity building that Agnes talked about. Next slide. This is one example. This is a focus on neonatal mortality from Nepal. What you can see is that they had a 42% decline in their under 5 mortality was due to reduction in neonatal mortality. Over there on the right, in the somewhat distracting changing, you can see that the drop that happened, and while there were components that actually lagged behind, that the drop was seen across. How did they do it? Again, early recognition, earlier than most of the other countries, that neonatal mortality was going to be a problem, and they implemented new data collection. They implemented policies that addressed all 3 periods of risk for the baby: antenatal, perinatal, and postnatal. They leveraged their existing community health workers, the very famed female community health volunteers, to integrate selected neonatal evidence-based interventions, and increasing focus on higher level neonatal care. So you needed to look across the spectrum, and a clear equity focus on the curative and preventative with, for example, free delivery services. They were able to understand a number of their both national and global contextual factors, as well as individual and community factors, and work to improve things, for example, like women's empowerment as well as reproductive health. Their facility-based delivery increased from 9% to 58%, and neonatal mortality reduction dropped by 3.1%, but dropped even more in lower caste and indigenous groups. And from that, you can see a number of selected transferable lessons. Next slide. So these are just a number of key learning transferable lessons for other countries that have come out of our research, including strong donor coordination, engaging stakeholders, applying implementation with an equity focus, as well as a number of other ones that you can read here. And particularly, they really focused on primary health care. Most of them had strong community health worker programs, but again, they really focused on not developing vertical programs, but on building an existing primary care health systems. Again, another lesson for us as we think about the COVID response. Next slide. So these are some other cross-cutting recommendations, and you can actually see some specific country examples here. Again, in the interest of time, don't have to go for them. But these are not just sort of generic statements, but these are things which the countries actually did. So for example, with the stakeholder engagement and coordination, Rwanda coordinated donors and stakeholders in line with a nationally established vision, including improving primary health care. Bangladesh went more with a SWAP, a sector-wide approach, which required donors to channel funding to the broader health sector, not just favored programs. So each one of these actually tells you the strategies of how they actually succeeded. Next slide. Now, this was actually done with a large group of people, Gates Ventures and Bill and Melinda Gates Foundation for their support and funding, the in-country partners that did this, and a technical advisory panel that provided us great insight and advice as well as technical input. Next slide. And finally, the team, because this was really done by a whole group of people, including Dr. Agnes, who you will see, who you'll hear from immediately following this, as well as other individuals. And thank you so much for your time.
Wow, thank you so much, Professor Hirschhorn. That was just phenomenal to walk us through the really important issue of how to actually make all that happen was fantastic. And I think picking up on some of Dr. Fernandez and Professor Scher's points about things like context and how different messages can apply across different contexts was just fabulous. So now for the final speaker, Professor Binagwaho will also provide some specific examples of the power of implementation science.
Thank you, Tim. Thank you, great partners in this panel. My role is going to be simple. I'm going to take the study done that Lisa has just presented by taking the example of Nepal out of the 6 countries we have worked on, how and why to use implementation research approach to respond to COVID. Because we have realized that the strategies that has been listed in countries that has been exemplar for under 5 mortality are exactly the same strategies used by countries who have successfully responded to COVID. Next slide. So implementation research allows for countries to better understand their problem, the contextual factors, the evidence-based intervention that exists to solve that problem, and also to adapt the evidence-based intervention and the implementation strategies to the country needs and to the evolution of the problem in the country. For this, Kenneth, Lisa, and also Quintas has explained that. Next. These slides, I'm going to pass very quickly on it, but you will see that exploration, preparation, implementation, and adaptation and sustainment will be all along the response to COVID. And the what, when, why, how, and how also, as much as the contextual factors and the selection of the strategies and adapting the strategies to the evolution. Next one. So the key contextual factors in Rwanda and evidence-based intervention for COVID preparedness and response. First of all, Rwanda is surrounded by 5 other countries and is it's a country that is locked in the heart of East Africa. So everything we have is through transport by air or by boat, and after that, using truck through Tanzania or through Uganda and Tanzania and Uganda and Kenya. So this is an important factor because one of the response to COVID was the lockdown, how to keep goods that Rwandans are in need of entering in the country. The other factors is the lack of running water. There is one of the evidence-based intervention is washing hands. And with lack of running waters in village and in public places across Rwanda, how can people keep washing their hands and hygiene advice? The second is contextual factor is for all countries is the spread of this disease that we are still learning about. The number of asymptomatic people with COVID-19, how it spread in communities rapidly. It's a factor that many countries have taken in account and many countries have totally forgotten to take in account. So they have let the disease penetrating deeply in the community, and then if the strategies to fight the COVID is no longer the same. The other thing is what many developing countries face is the financial instability, meaning a lot of income are generated through an informal sector. And when you lock down, many people cannot have an income and then they don't know how to feed their family because their income, they don't have reserve. And it's a day-to-day production of money for spending day after day for feeding the family or respond to the need of the family. So the evidence-based intervention were known. They are the same for every country. Washing hand testing, contact tracing, quarantine and isolation, lockdown, and social distancing. The barriers are different, but the facilitators also are different across country. In Rwanda, strong national leadership with great coordination across sectors and great coordination of the partners have made the discussion of the evidence-based intervention and adapting them countrywide by everybody more easy. The fact that we have internet across the country and the phone penetration is wide have allowed to starting back economic activities using mobile money, and you can see down the slide, a taxi moto driver receiving his money, his payment without touching money and interact with the client through mobile money. This is an example. We had also 4 community health workers per village that have done great in sensitizing the population, helping the population to understand the evidence-based intervention and the strategies that were adopted. So the photo on the top shows you the washing hands done before people can take buses. And in Rwanda, there is not so many people who have a car. People travel by taxi, car, buses, or taxi moto. So before entering in any bus, you have to wash your hands, and the driver has been trained and make sure that it happened. Next one. A key implementation strategy is the use of data. And in this slide, you can see the case reported by day, every day since the beginning of the first cases, the first case, the 14th of March. We know the name, we know the place, we know the people the person has been in touch with at more than 80%. And we can see, you can see that the peaks are different and all have different causes. In the beginning, there was the imported case through plane. And it was solved with stopping airplane to come in Rwanda. And suddenly there was another big peak. And this big peak around the 25th of April was due to truck drivers coming from our neighbor's country. This was tackled, and I will explain how later. And now we have an increase, but the biggest number of new infection in Rwanda has never been above 100 a day. And it was when at the border, people stopped to respect the lockdown and start traveling between us and our neighboring countries and brought the infection back in Rwanda. You have on the also the day-to-day report the Minister of Health is doing through Twitter, through another social media for the people to know the number of cases, total number of cases since the beginning, the number of new cases, the number of people who recover, the number of deaths, and you can see that we had 5 deaths since the beginning of the infection and around 1,500 cases since the beginning. And the population is informed on day-to-day basis, and we know, you can see above that information, in which district the people are infected. And people understand why Ruzizi has been locked down longer than the rest of the country, and why also 6 villages inside Kigali were locked down during 2 weeks because the new cases were there. When somebody is if I'm infected tomorrow, I will not stay at home. I will be brought in a hospital. All my family will be tested, but also all my neighbors. So the contact tracing starts with me, but also locally. And when I, next slide. Other is integrating the policies and the new guidelines and policies in the old one, in the existing one, sorry, meaning education of health professionals, of community health workers and the population. It's also control the borders. You can see the top photos is a photo at the airport before the epidemic, the pandemic, and in Rwanda. This was a photo taken in January where everybody has to give information, name, where they're going, what was their flight, what was their seat, to facilitate contact tracing. The multi-sectoral coordination, I talk about it, and the photo down shows you that all the trucks entering in Rwanda have a GPS. Even when the driver stopped for pee, we know where he has stopped. And in case the driver is found positive because they have to test when they enter or when they go. And the place where the driver stopped on his way will be tested. And also maintain a primary focus on primary care, because vaccination, maternal and child health have to continue. We doesn't have to fight a disease to have more deaths due to the disease that we are fighting on day-to-day basis. Next one. Other key implementation strategies is promoting innovation. You can see on top there, robots. The airport is going to open, and also there are some public spaces where those robots going, and when they found a human being with high temperature, they create alerts, and this person is propose a test. Also innovation by producing what people were not producing before. You can see there an association of women producing masks that are on up standards, and because of the lack of masks, their production were really welcome and they have made a living. Accountability, the Minister of Health, the Minister of Local Government, even the head of the village are accountable to some key indicators, like who doesn't have enough money to have food every day for the family. This is the head of the village. I'm living here where you see me. My head of the village lives 3 roads below me, and he knows who is in need around us. And there is a national budget for feeding the people we need. There was another national budget secure for the testing. Tests were free, because we know that if people have to pay, sometimes they cannot pay, they will not test and spread the disease. So everybody is accountable at a certain point. And strengthen the health sector by, and including the community health workers, by education, and give them the tool to perform what we ask them to do. Focus on equity was a key strategy that we found across all countries that have performed well to reduce under 5 mortality. And focus on equity is something that we found in all countries where they have done well in the response of COVID. And after that, providing financial support for people in need because of lack of income, and giving direct food as well. Next one. So those key strategies has been adapted. I told you about contact tracing, and there are some countries who have chose immediately massive testing. And we can see that now, because it's we have focused a place of the spread of the disease, we test where we found danger, like the taxi drivers are tested systematically and regularly. All the people working in the response are tested once a week. So all the people crossing a border have to test, and when they come back in Rwanda, they have to test. 4 days later, they have to test again, and they have to have 2 tests negative before being allowed to join their family. So contact tracing is continuing and adapt according to the need of the day. Sampling in the communities is also done. If I'm traveling in Kigali, I can have a test, propose a test, and randomly. And so my job was to show you that the EBIs are known, that the implementation, that the contextual factors have been studied, that the implementation strategies has been adapted to the contextual factors to implement at the best the evidence-based intervention, and that using implementation science, we adapt day after day to the need and to the change. Thank you. Next one. Thank you.
Thank you, Professor Binagwaho.
Yeah, I just want to say that everything I said is really built on what the former speakers have developed.
Yes, that's one of the points I was going to make. I thought it was a fabulous presentation, weaving together the messages from our first 3 speakers and really highlighting, I love that idea of paying attention to the way in which not just problems, but the way in which problems evolve, and being able to use implementation science to adapt what we do to remain effective in addressing problems. Okay, so now we have the question section. So the opportunity for the people attending the webinar to influence the information that they're hearing. So we've had a really wonderful time of laying out implementation science and how it can benefit health problems and serious global problems. Let's now go to some questions. So there've been questions coming in, and our fabulous UGHE staff have been collating them all in the background while we've been going. So I'm sorry if we can't get to all of the questions, but I'll do my best in getting through some of the ones that are here. So firstly, over to you, Professor Scher. There's a question about, this is really interesting. So, since the context of the origin of implementation science is in the global north, such as the US, and there is a need to adapt definitions and methodologies to meet contextual needs in the global south, how are you working with ally universities like the University of Global Health Equity and your students from developing countries to achieve a globalized conceptualization of implementation science?
Thanks. That's a very interesting, actually very tough question, just because, you know, the way we speak to each other varies so much globally. You know, we may talk about implementation science, implementation research. Others may talk about health systems and policy research. And there's a lot of similarities across these different concepts. I always push to not get caught up in this specific terminology or vernacular, because I think what happens is we become very siloed and focus on differences between each other rather than the commonalities. So that's why I drive to really think about, well, what's the motivation of the field, and what are its key tools and resources that it contributes, and try and find those touch points rather than saying, well, I'm a dissemination researcher, not an implementation researcher, or I'm a health systems researcher, not an implementation researcher, and focus more on what do we all bring together as a community of public health practitioners, medical practitioners, researchers that can drive really our intent forward, which is improving health of populations through better delivery of evidence-based interventions. So to the question of what we are doing at the University of Washington to try and change or improve a generalized understanding of implementation science, I want to focus on our PhD program, which started in 2012. It's actually two streams in our PhD program. One is health metrics and the other is implementation science. And it's conceived as one program. So there's a lot of interaction across the two tracks. But our implementation science program has about 40 active students. Half of them are from low and middle income countries. And we are focusing on a really diverse set of students. So we're not focusing on just researchers. We see our students coming from and going to really three different areas. One is academic institutions. So a lot of our students are junior lecturers or researchers at low and middle income country institutions, particularly where we have a lot of interaction. So University of Nairobi, Eduardo Mondlane University in Mozambique, and a number of universities in China and elsewhere. So part of this process is training and working with researchers and academic instructors from low income country academic institutions. Now, the second group are those who are going to come from and go to ministries of health. So Dr. Fernandez, as an example, somebody who has been a very senior leader in the Ministry of Health of Mozambique and also an implementation researcher. So he is PI on a large NIH-funded project and a foundation-funded project in Mozambique, which is really trying to drive forward an agenda of implementation research around maternal, newborn, and child health in Mozambique. So we see that as a key set of stakeholders for those who are going to be working in ministries of health, because they are the drivers of large scale change at a country level. And then the third group are those who are going to work in kind of this group of bilateral, multilateral institutions, foundations, international NGOs or national NGOs, those that are partners for implementation, largely not driving implementation itself, but involved in capacity building or implementation of large-scale interventions. So we have a large body of international students. We're working with them to bidirectional learning, understanding what resonates with those who are in our program. So we're not just driving forward a teaching agenda that comes out of a high income country model, but to understand how does this work in a low middle income country setting. And so a lot of when you get down to the research that is being carried out by students in our program, a lot of what they're doing are trying to test and adapt and retest how some of these key tools and resources out of implementation science behave in other settings and really tweak them in a way which makes them more applicable, understanding that we can't just take one model and put it into a new context and assume it's going to work. We have to be thoughtful and learning along the way as we try and take this field of implementation science and work in other settings.
That's an awesome answer. Thanks so much, Professor Sher. And I think this theme of being aware of the differences in different contexts while focusing on the things that are important and common across different contexts is coming through really, really strongly. It's such an important area for implementation science. I want to stay with the education and training idea for just a little bit longer. There's another question that's come in. I'd be really interested in your thoughts, Professor Binagwaho. The question is where and how implementation science merges with medical education. I feel a lot of extra scientific factors are responsible for delivering healthcare. How do we prime the next generation of medical experts, global health leaders, and health policymakers to understand and make good use of implementation science? Another great question.
Especially in our continent, the knowledge about research is too low in general. We need really to increase the capacity to do research. And the capacity to do research in implementation science, using implementation science, is even more important, because if we take today all the EBIs we already know, the evidence-based intervention to fight the diseases that are known, we will save not thousands of lives, millions of lives. without inventing new tools and without searching for new EBIs. So it is really important because we need to save life. We need to use and maximize what we have. So we should teach research to all clinicians, to research to nurses, to doctors, to community health workers when we educate them. And we need also to teach implementation science, meaning teaching everyone what are your contexts, understand your context. What are the EBI, the evidence-based intervention that are known? How can you adapt that to your context? And how can you use, which strategy to use to implement the EBIs to respond to the problem? Those are simple things that each doctors, each nurses, each community health workers should know. So we need to teach that.
That's brilliant, thank you. And it's so when the four of you explain these kinds of ideas, it does sound so simple and straightforward. It makes one wonder why it hasn't been happening for much longer than it has. Okay, over to you, Dr. Fernandez. Professor Binagwaho mentioned the idea of capacity, so I want to dwell on that a little bit longer. There's a question. Considering that there is no one-size-fits-all implementation science capacity building framework, what factors and sincere steps help better adaptation and contextualization of frameworks?
Thank you. First, I wanted to agree with all that Professor Agnes said before. And as I said in my presentation also, context always matters. And we have to be smart enough to understand the interventions and be able to adjust the interventions to our own context. When it comes to capacity building programs, it's really important to understand that capacity building itself is a challenging program. It's not only about identifying the right people in training. It's not only about developing the appropriate materials and having people in the same room or defining the appropriate model to train people. But it really requires thinking carefully in a framework and having that in a context in where we are able not just to implement it, but to learn from it and keep improving the program. It requires establishing programs that address some of the core elements, including thinking about sustainable relationships with critical stakeholders, and build something that to me is really critical. It's about building trust among the key stakeholders, because if we don't do that as the underlying, as the basis for a capacity building program, then we are taking the risk to keep doing business as usual.
Okay, wonderful. Thank you so much, Dr. Fernandez. And now I have to confess to being in a bit of conflict. Professor Hirschhorn, there's a couple of questions coming up that I think, and I'll save them for a little bit, I think they can be combined together, and I'd be really interested in your views on those. A question just come in, Professor Binagwaho. The question is that you described a very impressive response to COVID that was mobilized in Rwanda. Again, this is getting back to what lessons can be applied across different contexts. So what lessons can be learned from that example when hoping to scale this up in large populations like the US, where we are totally failing in containing it? So some comments there, and perhaps some of the other panelists might have some views on that as well.
Let's start by Lisa.
Okay.
Thank you, Agnes. I mean, I think it really is, you know, and this was the challenge that we had when we started to do the under 5 mortality exemplar work. Everybody said, oh, it's Rwanda. It's like Rwanda. And the answer is yes, and it's really the strategies and the culture that people are applying. And it's the accountability. So if you sort of think about what was Rwanda able to build on in terms of the leadership, in terms of the existing data utilization. So these are contextual factors that you can leverage. But if you don't have that, if you don't have the leadership, I mean, what we see in the US is that instead of national, it goes down to then more local. But you have some leaders who actually are using data, who have accountability. Some of the states have similar types of, I don't think they tweet it out, which would be a good thing, ways of doing that data utilization. So it gets at another comment somebody had, which is, you know, what are the core elements? So what are the things that that Rwanda is able to leverage to be able to accelerate their change? And what are those factors? We talked about the fact you have to acknowledge the factors. You have to decide if you can utilize them or you have to address them, meaning how do you actually expand the data utilization as you're actually doing that? I think the community engagement is absolutely critical, and for places that don't have community health workers, there are other means of figuring out how do you actually engage so that the community has buy-in and understands what's actually happening. And then some of this is building on trust. And if the trust doesn't exist, it does make it much more difficult. And so figuring out who are actually the trusted opinion leaders, who, if it's not within the direct political or within the direct Ministry of Health, who can actually be engaged to actually continue to spread. So it's a little bit of really going in and thinking about what are those contextual factors, what are the strategies that are being used, and what can therefore be transferred to other countries. So no secret sauce, just strategies and figuring out which contextual factors you need to adapt to or to address.
In one word, implementation science is like doing the first step on the moon. It's not important that it was Peter, Paul, or Kenneth, or Lisa who do it. The way he just walk, knowing how to walk, and he did it. For implementation science is the same. We have principle. That means you need to know your context. You need to do the review of literature, the desk review, everything to know the evidence-based intervention. And you need to know your contextual factor, your contextual factors, globally, nationally, locally, and just decide the strategies accordingly. And if the US will do that, they will solve the problem in a month.
Thank you. Professor Dr. Fernandez, do you have any further comments? It's interesting that focus on principles, Professor Binagwaho, that's come up in one of the questions, that principles transfer across contexts, whereas programs don't necessarily. They're the things that have to be adapted. So I'd be interested in some other comments from Professor Sher or Dr. Fernandez.
If I could just chime in a bit, and I want to comment on what we mean by evidence-based interventions, because I think what the Rwanda experience demonstrates is the evidence-based intervention doesn't have to be a vaccine or a therapeutic a mechanism. We have a strong set of evidence-based interventions to prevent COVID. Whether it's mask wearing, social distancing, testing, contact tracing, and what Rwanda is doing right we are not doing in the United States. And you can see it's a disaster. So thinking about evidence-based interventions as much broader than just a pill or a vaccine, thinking about it as anything that could work, whether it's a program, a policy, a guideline, or a medicine or a vaccine, we just need to be expanding our thinking, and then think about what do we need to do to translate that to other settings. Because I think the Rwanda example is what we can take from it is leadership, good planning, good execution. And that's what's not happening right now. And governance and leadership.
No, since 2006, we are writing about it. So it's not unknown. That means the way you govern impact the result you will have. It's not about money. It's about the way to do business. And you do that because the why, the how, it's implementation science. So if you, first of all, you refuse evidence, because the first thing is to go evidence-based, backed by science. If you refuse science and say, oh, God will help us, the virus will not spread if we go to church. There are some leaders who have said that. Okay, the result is expected, then you get it. Or it's not important. Yeah.
Yeah. Thank you. Okay, so we've just got a few minutes left, and I'm going to switch back to you, Professor Hirschhorn. There's a question about where scale up comes in. Is that during implementation or adaptation, or in the last stage? Where would you place that?
So that's a really, really important question, because I think there's, the world is rife with really great small projects that actually never go anywhere. And 2 years later, nobody even remembers them. What we found the success was really that they began to plan for scale up from the beginning. And it depended a little bit on, so it should be at the preparation phase and exploration phase. So if there's something that would work perfectly in one district and has no impact on scale, unless you want to do that as an example to show that it is indeed feasible and effective in your own setting, and use that to then advocate for the resources that are needed, it's not necessarily the right evidence-based intervention to choose. And there's a lot of debate right now about, in COVID response, should the resources be put into the prevention, into oxygen, or into ventilators? And I think thinking about in that sense is a really important one. So I think the answer is it has to be from the very beginning. Some of the countries that were focused on equity on purpose actually said, look, we're not going to scale from the start. We're going to meet the people most in need, and then we will begin to scale. Other ones said, look, we're going to start to see if it's feasible with the places we think it's going to succeed. If it succeeds there, we'll go further. But it has to be from the start. And it's scale and sustainability. And it has to be scale with quality for it to continue to be effective. And some of the strategies that people did about incorporating into national programs, whether they were within the monitoring evaluation, whether in the policy, whether they were in the national strategic plans, were all part of thinking towards scale from the very beginning. So there were strategies that actually helped. And you're completely right. If you do it at the end, very hard to do.
That's a wonderful way to close off our webinar by commenting on the importance of what we think about at the beginning, and making sure that we plan things thoroughly from the beginning to end up where we want to be. I just, in closing, I want to remind everyone that this session will be available as a recording on our UGHE channels, including our website and across our social channels. I absolutely want to thank the four incredibly knowledgeable and talented panelists. Thank you so much for your time tonight. And thanks too to our UGHE staff, Laura, Nick, Elise, and Raisa. Thank you for your time in making all this happen. Professor Binagwaho, did you want to close off with some final comments?
So I thank my colleague in the panel, because I have a lot of fun doing it, and I learn, and I love learning. I just want to remind that implementation research is a part of involving science, but we have to know that physics began thousands of years ago and still continue to involve with quantum physics. So what I can tell the world is ignoring implementation research is killing, because using them avoid people to die and save life. So therefore, the number of lives we lose by not using implementation research should not be accepted. So today we have shown what is implementation science, how with the exemplar project we did with Bill and Melinda Gates Foundation and Gates Venture has proven that we need to, the implementation science can help countries to identify what to do, why, and when. And if in Africa we don't have enough knowledge in research, we have even less knowledge in implementation research, but the whole world need to make progress in knowing what is implementation science and implementation research is. And when we see that we have, as I said before, enough evidence-based intervention known for the disease to which that we are all facing on Earth, using what we know could already save millions without new evidence-based intervention, without new tool. So at the time of crisis like today, with the COVID and the economic crisis that are going side by side, and the scarcity of funds, it's even more important than ever to use implementation science. And I hope that today, team, the webinar you have led will have helped advance health and wellness in the world.
Thank you.
Thank you.
Thank you. They're profound words to finish the webinar with, Professor Binagwaho. And just in closing, there were more questions that came in. We'll develop some answers to those questions and have them on the UGHE website as well. Thank you so much to the panelists and to the 100 and more people who have been with us right up till now. So good night, everyone, or morning.
Bye-bye.
Bye-bye.